Hey there.
Hey.
Sorry to keep you guys waiting. I have several OR cases today, and I got called to another room as soon as we finished up. Actually, my partner, Dr. Gode, and I put the stent in together. We took a look inside of his windpipe and basically deployed, it's called a self-expanding metallic stent. So you guys know what chicken wire looks like. Yeah, so imagine a tube of chicken wire that has like saran wrap on the outside of it. And we were able to put that into the air passageway to the left and pull it out and extend it into his windpipe and kind of exclude the area where that hole is in his, on the right side. So that right side is completely blocked off. So when he is breathing, the air is going primarily from his windpipe into the left lung, and it's decreasing the amount of air leakage into that right chest, air leakage and secretions. Now, it's obviously not going to be completely airtight and watertight, but it's going to be a heck of a lot better than what it was beforehand. And the tracheostomy tube that we placed earlier is sitting right above the stent. So if you have the stent right here, the tracheostomy tube is a little bit higher. And that, it looks like it's in great position. We confirmed the positioning both with the scope, where we're looking at it with our eyes. We also took an x-ray and confirmed the positioning with an x-ray.
So where's it at?
It's in his air passageway going from his windpipe into the air passageway that takes air to his left lung. We also put a chest tube in on the left side. He was building up some fluid over on the left side. And that's just probably a response to the IV fluids he's gotten and this whole inflammatory infectious process. It's not, it's certainly something that's very common in this particular patient population. We then went in, I kind of dug around a lot manually in that area where he's had the lung removed. To try to see if I could identify any undrained pockets. I couldn't. Looking at his CAT scan, he may have a little bit of fluid collection toward the back and kind of close in toward the middle part of his chest. And there's no way I can get to that from this approach here. What we may do is in the next day or two ask the radiology doctors to take him to the radiology department and using the CAT scan as a guide, put a needle into that area, drain any fluid that may be present, and possibly even leave a drainage catheter in there to remove the fluid. And we just kind of washed out that wound and packed it again. Okay, so that's where we are. Any questions?
I don't think I have any today.
I never have any.
I always
My
have some,
godchild
but
hasn't,
that
but
cause I hadn't been here a couple days,
I'll
so at
just
least
keep
that.
saying thank you. I'm grateful.
You don't have to tell it. That's what we're here for. Yeah, that's what we're here for.
Well, we're very grateful, but here's my question. The antibiotics for that bacterial stuff, that's all done? He's free and clear of that bacterial infection, or how is that?
No, first of all, the infection that he has it's kind of what we call multi-drug resistant. It's very hard to treat with antibiotics, and that's one of several reasons why we have his chest open. Drainage is always better than antibiotic therapy. It always trumps antibiotic therapy if you can drain. So we're attacking it from two fronts. We're giving him antibiotics, but we're also packing this wound every day. And the material that we soak our gauze in to pack the wound has a very potent antibacterial agent in it. And so hopefully the combination of those two will kind of help this.
Do you feel like
process.
it's getting better?
Well, his white count, it may go up just because of what we did today, but his white count had come down to normal. And you know, he was not on a high amount of medication to keep his blood pressure up, which we see in people who have sepsis, where they basically have uncontrolled infection, and that's their body's response to the uncontrolled infection. He had no evidence of that. And we even were able to decrease the amount of support that we were giving him on the breathing machine. The problem is that as we decrease the amount of sedation, he is okay initially, then he gets agitated, and then we have to go up. It's kind of like a seesaw type pattern. It's a fine line that you have to walk. And that's not unique to him. We see that very frequently in people who are on the breathing machine.
Okay.
And so I think clinically, we have a pretty good handle on the infection. But he still is in a precarious spot. He has pretty significant lung dysfunction. He was pretty much on the tightrope before he had this pneumonectomy. And I can fathom that. I don't know what he was like immediately after the surgery, what his breathing pattern was like. I can imagine he was probably fairly short of breath.
No.
After the pneumonectomy, after he had that lung taken out?
Yeah, okay, I'm sorry.
He
I'm
walked
backing up
in-
to what you said, what you were saying before. He was fine before they did the split lung thing. Like, that lung function was great. That's why they took the other one out. And then after, for a couple of days, he was great. He was walking around doing fine. It was 2
He didn't
days.
even need oxygen. He was walking in CCU.
Nothing.
Yeah.
I mean, whatever he got the infection from.
Yeah. Well, I'm a little surprised, with his smoking history.
That's correct.
And the
They
fact,
call him like the poster child for
Yeah,
both times
he's
because
definitely
he's
one
so
of those.
determined.
Mhm.
You wouldn't believe it seeing him right now. I know we keep telling you that, but
Yeah.
seriously, like the most remarkable patient you've seen. Like, he was determined and he
Yeah.
was getting up and he was.
He
I mean-
got progressively worse, Doc.
Yeah.
After the surgery, I remember Dr. Feinberg a week later went in with a bronch
yes.
because the first 2 days Terry was fine. He was
Yeah.
breathing fine. They were doing the treatments, but he didn't need a lot of oxygen. We got home, he didn't need any oxygen. I was making him use it,
Yeah.
but we had the thing. We were checking it. He was going clean the pool. Dr. Feinberg was concerned because Terry had some wheezing going on. He couldn't cough anything up.
Yeah.
Feinberg went in a week later with a bronch.
Yeah.
And we noticed Terry went downhill from that.
Yeah, and that's probably at some point that area was probably starting to open up, and whatever fluid anytime you take out the entire lung, the side that you take the lung out from fills in with fluid. That's just the body's natural
Okay.
response. If you have a hole in the air passageway that you cut, some of that fluid is going to get into your air passageway and leak into your good lung. And that can cause problems. I mean, you're living on one lung, now your good lung is getting some of that.
Yeah, it was a day you could see him.
Yeah.
It was definitely.
He
It
never
definitely
ate.
makes
It was
sense.
just it was a 3-week painful process that I watched.
Yeah.
And the doctors were like, I'm grateful for where he is now.
So, getting back real quick, and I'm so sorry, but the reason I brought up the bacteria is because I know he went into AFib, and I guess from learning a little bit in my life, knowing that some types of infections put strain on the heart, I'm wondering if those two things coincide.
No. I mean, he could have gone in atrial fibrillation just because he decided to go in atrial fibrillation.
Yeah.
It has nothing to do with
Okay.
injection.
Curious.
His magnesium level could have been low. His potassium level could have been low. There are a million and one different reasons why he went into atrial fibrillation. Now, he could have gone into AFib because he was septic. He could have gone into AFib because we had him on medication to help support his blood pressure. Those medications can also ramp up the reactivity of the heart. It makes the heart puts it in overdrive, and makes it very sensitive, and makes patients more prone to develop irregular heartbeats like atrial fibrillation.
And the paralytic, how long is he going to stay on that now again?
I would probably start to wean him on tomorrow, but again, if we get into a situation where he is kind of fighting the breathing machine, we'll have to put him back on the paralytic and just kind of, not long term, put him on it, let him cool off, let him settle down, wean it, and then kind of play around with the sedation.
And the Seroquel, I find since he's been on Seroquel, it's like, I mean, I'm not saying he don't, I'm just, I mean, I don't know about you, I'll see a difference since he's on, the Ativan was one thing, but Seroquel,
Yeah.
I mean, it's like he's just got
Well, the
this.
nurse should explain that they wanted him
No, that's
in
fine,
a
that's what I'm
state of
asking,
agitation
Not-
or
yeah.
not. They didn't want to make him
right.
whatever.
The problem is that with the stuff that we normally sedate patients with, it's IV. It
Yeah.
requires a drip.
Yeah.
So you constantly are infusing fluid into the patient in order to deliver the medication. If you do that, and if you have 3 or 4 different medications, it adds up.
Yeah.
You know, it's like saving money. You
That's why
save
he's
money
swole,
here, there,
yeah.
and everywhere, and before you know it, you have a lot of money. You have a lot of fluid
Fluid.
into him. That remaining lung gets full of fluid, and that can be fatal. And so we kind of had to back off,
Right.
and that's part of the reason why we put him on the Ativan and the Seroquel. That's
Yeah.
stuff that can be delivered
Delivered,
into
yeah,
his
and
intestine,
yeah,
as opposed to
doesn't have the
that.
bolus, yeah.
Makes sense too.
I trust in everything. Thank you.
That's true. That's what we're here for.
We're all grateful, thanks.
That's what we're here for.
His like blood gases, have those been okay? Kelly will ask. I guess he asked a dose. She said something. Is he?
Acidotic.
Yes, yeah.
His blood gases have been closer to normal. They're not perfect,
Okay.
but he definitely has been. It's been a heck of a lot better than what it was.
Okay.
Certainly, the first few days that he was here, I was extremely.
Yeah.
Now, I don't want to paint an overwhelmingly optimistic picture. I don't think that he is about to walk out of here anytime soon, but I was very concerned the first few days about whether or not he was going to be able to make it from one day to the next. He was getting pretty septic, pretty ill, and all of a sudden he kind of turned the corner. His white count went from a peak of around 20-something thousand to within the normal range. The amount of oxygen that we had to give him, the amount of force that we had to provide in order to get the oxygen into his system, all of that pretty much settled down. We didn't have to put him on a ton of medication to support his blood pressure. Now, sometimes you have to put patients who are on the breathing machine on medication to support their blood pressure because the sedatives that you give them, they in and of themselves will cause the blood pressure to drop. And as you're having to increase the amount of sedation that you give to the patient and they're septic, all of that promotes the dilation of the blood vessels. As the blood vessels go from this to this, the blood pressure will plummet. And so it's, again, a lot of back and forth.
All right, I'm good. That's enough.